And obviously we have a major intervention to prevent transmission is hepatitis B vaccination. What we're talking about today is how do we reach the millions of persons who have already become infected and do not know their status and need some ongoing management to identify those that would benefit from treatment, which ranges about 10 to 30% of people with hepatitis B need treatment. As I mentioned before, the number of deaths from hepatitis B have gone up over time, and it's become a problem. And as I also mentioned earlier, the global burden of disease out of the University of Washington has projected that growth for hepatitis B and hepatitis C on through 2040. And so by 2040, 2.2 million deaths from hepatitis B to hepatitis C. Of those, about 1.4 million of those deaths would be related to hepatitis B. So that's the status quo that we would like to change. Now, we all recognize that there's a lot of uncertainty around a projection out to that level. But I think you look at this model and other models, they all show that you're going to get an increase in hepatitis B-related mortality over time if we don't do a better job of testing and linkage to care. So that's our challenge. As I've already noted, it's very, very poor almost all over the world in that's testing and linkage to care. So that's what we're going to be exploring in this session. The current regimen, 1 pill a day of tenofovir or TAF or entecavir, you do get improvements in lowering viral replication rates and slowing the progression of liver disease, liver fibrosis, and progression on to liver cancer. So you do get benefits with the current therapies. There's hope that new therapies, which could create what's called a functional cure for hepatitis B, would give you even greater benefit and maybe simplify management. But the point is here right now, we do have a very valuable intervention that could be life-saving for literally millions of individuals. And then the technical research to find that functional cure is ongoing, that we would like for programs that have already been set up with the current regimens to then be made more impactful by new therapeutic options. Hepatitis B, there are recommendations for hepatitis B testing by WHO for the world based on prevalences and risk factors. This just shows you in the United States, we focus on migrant populations because of they have the highest prevalences, particularly people born in Asia, but also people born in Africa. And then we have recommended certain linkages to care strategies and show that they're very cost-effective to be implemented as a country. And the U.S. Preventive Services Task Force in the U.S. Now supports that as a no-cost intervention, the testing, for persons in their health programs. So that's has been very helpful. In our country, as I think we'll be hearing more in a moment, there are proven interventions that improve testing and linkage to care. Professional education, community education, socially, culturally, language-appropriate programs for communities, patient navigation services, clinical decision prompts, et cetera, all have shown to improve this testing and linkage to care cascade in the U.S. and I believe elsewhere. But when you really look at the literature, and I would like to be corrected on this, I would like to be wrong about this, I'm really amazed at the lack of evidence supporting various care models for hepatitis B, particularly in low and middle income settings. This is the Prolifica study in the Gambia showing high acceptance of testing, good linkages to care. Not many of those individuals needed treatment based on recommendations from ASOD or EASL for developed countries. But the point is here, keep in mind that rising mortality, large health consequences from hepatitis B and the relatively sparse care models to guide what we're doing in Africa and elsewhere. And I think that's one area that we really need to improve upon. To sort of build on, from what Margaret was saying, these costs of fully implementing a hepatitis B or hepatitis C elimination program is really a small proportion relative to the full-bodied campaigns underway for HIV, TB, and malaria. In total, you're looking at about $140 billion between 2015 and 2030 for hepatitis B and hepatitis C, compared to $342 billion for HIV, TB, and malaria. Of that, about $89 billion of that is for hepatitis B vaccination, testing, linkage to care, and treatment, with dramatic reductions, maybe even a 40% reduction in that cost if you successfully integrate it into existing health systems. So this sort of this UHC approach could really help lower that cost even more. So these costs in one way may seem large, but when you put it in context and the huge benefit, I think it really shows this to be a very feasible and very cost-effective program to put in place. So in summary, hepatitis B is a big public health problem. People who are already infected need to be tested, linked to care and treatment. We need to build the evidence base in a more full-bodied way so we have interventions to guide our actions. We need to be improving the public awareness, political awareness about the growing threat of hepatitis B for populations around the world, and so that we get more support for hepatitis B testing and linkage to care. Thank you.